Okay, good evening, everyone. I am Dr. Rupali Sehgal. I have done my MS General Surgery from Guru Gobind Singh Hospital, Faridkot, and right now I am doing my senior residency at the same place. So today I'll be discussing about inflammatory bowel disease. It's going to be a very short session, and we'll be discussing mostly about Crohn's disease. So let's start. So inflammatory bowel disease is a chronic inflammatory pathology of the GI tract. It can be one of the two. It can be Crohn's disease or it can be ulcerative colitis. Now, the common thing between the two is that the etiology of both is unknown. That is, both of them are idiopathic and both of them have a chronic relapsing course. First, we'll discuss the risk factors. The greatest risk factors for IBD as a whole is family history. Then there is genetic susceptibility. A lot of genes have been identified, like the NOD2 gene, the IRGM gene. People who have mutations in the symptom of Crohn's disease is chronic diarrhea, while the second most common symptom patient presents with is intermittent colicky abdominal pain. Now we can trace these symptoms according to the pathophysiology. We'll discuss it now. Whenever a patient has ulcer, the ulcer irritates the bowel wall and patient has increased frequency of bowel movement. So the patient presents with chronic diarrhea. Now, once the ulcer can have two fates. The ulcer can either fibrose and heal, or it can penetrate into the bowel wall. If the ulcer heals or there is fibrosis of the ulcer, it will lead to stricture, and that stricture will ultimately cause intestinal obstruction. This intestinal obstruction is the actual cause of the second most common symptom that patient presents with, that is colicky abdominal pain. But if the ulcer penetrates through the bowel wall, it can involve the adjacent bowel loop.
Constant stomach pain, frequent diarrhea, unexplained weight loss. These could be signs of inflammatory bowel disease, also known as IBD. IBD mainly includes Crohn's disease and ulcerative colitis, conditions causing chronic inflammation in the gut. Early diagnosis through proper evaluation and investigations is extremely important. With the right treatment, lifestyle changes, and medical support, patients can manage symptoms effectively. Awareness saves lives. Don't ignore persistent digestive symptoms. Consult a gastroenterologist today.
Disease or as a penetrating disease, we have discussed it. The options for a stricturing disease will commonly present as obstructions, intestinal obstructions. So we can go for stricturoplasty or we can go for resection and anastomosis. There are clear-cut indications on when do we have to do what. Now, if the stricture is less than 10 centimeter of the bowel wall, we can go for henchimiculac stricturoplasty. I'll share the images. How do we do these? And if the stricture length is more than 10 centimeter of the bowel length, we can go for Finney's stricturoplasty. But when is stricturoplasty contraindicated? If there is a perforation at the site of stricture, there is a stricture and there is also a perforation there, we can't go for stricturoplasty there. Rather, we should not go for stricturoplasty there. If there is a possibility of a malignancy at the stricture site, we should not go for stricturoplasty. If I am in penetrating disease, now penetrating disease means there was an ulcer which involved the entire bowel wall and came out to involve the adjacent loop to form an enteroenteric fistula, or it involved the skin to form an enterocutaneous fistula, or an adjacent organ like the urinary bladder to form an enterovesical fistula. But if there is an enteroenteric fistula wherein the contents of the bowel are being poured into the bowel, maybe into an adjacent bowel loop, okay, but there is no outpouring of the bowel contents into the peritoneum, there are no signs of sepsis for the patient, that patient does not need surgery. Also, in cases of enterocutaneous fistula, we check for the output of the fistula. The low output fistulas, that is the cutoff is around 500 ml output per day, we can give a trial of conservative management. Now, what this conservative management means?
Inflammatory bowel disease isn't always limited to inflammation alone. In some patients, the inflammation penetrates deep into the bowel wall, leading to fistulas, abscesses, and serious complications. Symptoms like severe abdominal pain, fever, or drainage should never be ignored. Timely diagnosis and advanced therapies can help control disease progression. Understanding penetrating disease is crucial for improving outcomes in IBD patients.